Hello, and welcome everyone. My name is Dr. Yo, and I've been tasked to talk to you about diagnostic workup and staging for testicular cancer. In this pre-recorded lecture, we'll be walking through the diagnostic workup and staging of testicular cancer, drawing primarily from the 2026 European Association of Urology guidelines, published in European Urology in April 2026, as well as with reference to the NCCN version 1.2.2026. And staging is actually based on the UICC TNM 9th edition, released in 2025. Testicular cancer is a disease where the stakes of getting the workup right are high, both in terms of not missing curable disease, but at the same time, not over-treating patients who are already highly curable with minimal intervention. By the end of this lecture, you should be able to describe the initial clinical evaluation, interpret the role and limitations of scrotal ultrasound and serum tumor markers, apply the current UICC 2025 TNM staging system, use the IGCCCG prognostic classification for metastatic disease, and know exactly when to order a brain MRI, and also to distinguish the key areas where the EAU and the NCCN guidelines might diverge. Testicular cancer accounts for about 1% of adult neoplasms and 5% of urological tumors in the Western world. Incidence rates of 3 to 10 new cases per 100,000 males per year is usually reported in Western countries, and the incidence continues to rise, predominantly in industrialized nations. Despite this, the prognosis is excellent, with over 95% long-term survival across all stages. The peak incidence of testicular cancer is in the third decade for non-seminomatous germ cell tumors, and the fourth decade for seminomas. At diagnosis, 90 to 95% of cases are germ cell tumors, and only 1 to 2% are actually bilateral. The risk factors are grouped around the concept of testicular dysgenesis syndrome, things like cryptorchidism or undescended testes, hypospadias or impaired spermatogenesis. Other risk factors are also related to disorders of sex development, a positive family in first-degree relatives, as well as the presence of contralateral testicular cancer or testicular tumor in situ. A genome-wide association studies have also identified susceptibility loci. One clinical note: prior platinum-based chemotherapy actually lowers the risk of metachronous contralateral tumor, which is relevant when counseling survivors. The WHO 2022 classification, which the EAU 2026 guideline endorses, divides testicular germ cell tumors into two fundamental categories. The majority are germ cell neoplasia in situ derived, or GCNIS derived. That is, they arise from germ cell neoplasia in situ, and this subdivide into seminoma and non-seminoma. Non-seminomatous elements include embryonal carcinoma, yolk sac tumor, choriocarcinoma, and teratoma. And most non-seminomatous germ cell tumors are mixed. This distinction is clinically critical because it drives every downstream management decision. The non-germ cell neoplasia in situ derived group, things like prepubertal type teratoma, prepubertal type yolk sac tumors, and spermatocytic tumors, have a separate pathogenesis and generally a more favorable biology. This tends to occur at extremes of age. The European guidelines explicitly recommends expert GU pathology review of all orchiectomy specimens for optimal management. So how do these patients present? The most common presentation is a painless testicular mass, though as many as a third of patients do have some degree of scrotal or testicular discomfort, which can unfortunately lead to delayed diagnosis if attributed to epididymitis or trauma. Gynecomastia occurs in a small subset and is a clue to a HCG secreting tumor, things like choriocarcinoma in particular. Back or abdominal pain suggests retroperitoneal lymph node involvement and should prompt urgent imaging. Supraclavicular lymphadenopathy is a red flag for advanced stage 3 disease. The key clinical pearl here is non-negotiable. Any solid testicular mass must be presumed to be malignant until proven otherwise. Pain itself does not exclude malignancy, and watchful waiting is never appropriate. The next step after discovering a scrotal mass is always a scrotal ultrasound. Bear in mind that 5% of germ cell tumors present from an extragonadal primary site. The mediastinum is the most common, and in a male with mediastinal mass and elevated alpha-fetoprotein or HCG, testicular cancer should be at the top of the differential. A systematic physical examination is a strong recommendation based on the European guidelines and should cover all lymph node stations, including supraclavicular, cervical, axillary, and inguinal. Supraclavicular and cervical nodes are particularly important because they indicate stage 3 nodal disease from direct drainage beyond the retroperitoneum. We also examine the breasts of males for gynecomastia, assess both testes for masses, volume, and consistency. A normal testicular volume is 12 to 30 mils, and we also palpate the abdomen for retroperitoneal mass. A large para-aortic nodal mass can be palpable and may be the patient's presenting complaint. Following physical examination, bilateral scrotal ultrasound is usually the next step in investigation and is a strong recommendation based on the European guidelines. The key technical requirement is for a high-frequency probe greater than 10 MHz with Doppler. This must be performed on both testes as we are assessing the contralateral testes for volume, germ cell neoplasia in situ features, as well as synchronous lesions. So what do we do about small incidentally found lesions? Well, the guidelines statement is clear. Virtually all lesions under 3 mm are benign. 87% under 5 mm are benign, and 70% under 10 mm are benign. However, and this is very important, there's no size threshold that safely excludes malignancy. No evidence supports following up any size lesion without histological confirmation if clinical suspicion is present. A scrotal MRI has higher sensitivity and specificity than ultrasound, but it is not recommended for routine staging. It is only reserved if ultrasound results are inconclusive, or if you're planning for testis-sparing surgery, or from differentiating paratesticular from intratesticular lesions. Alpha-fetoprotein, beta-HCG, and lactate dehydrogenase must be measured before orchiectomy. This is a strong recommendation based on European guidelines. So let's go through each one. Alpha-fetoprotein, with a half-life of 5 to 7 days, is elevated in non-seminal matrix germ cell tumors, specifically those containing yolk sac tumor components. The critical point, alpha-fetoprotein is never elevated in pure seminoma. If you have a patient with apparent seminoma on histology, but elevated alpha-fetoprotein, you reclassify that case as a non-seminoma, regardless of what the pathologist reports histologically. And this will fundamentally change the management. Beta-HCG has a half-life of 1 to 3 days. It is elevated in choriocarcinoma and mixed germ cell tumors. It can be elevated in up to 30% of pure seminomas. And this is in important context. A markedly elevated beta-HCG above 5,000 international units per liter specifically triggers brain imaging as per the European guidelines. Lactate dehydrogenase is non-specific but correlates with tumor burden and is used for risk stratification in metastatic disease. It can be elevated by hemolysis or liver disease, so interpret it in this context. Collectively, up to 90% of non-seminomatous germ cell tumors have elevated alpha-fetoprotein or HCG at diagnosis, with 39% having both elements. But normal markers does not exclude testicular cancer. Their sensitivity is limited and marker-negative disease is well documented. A brief word on emerging biomarkers, microRNAs, particularly MIR371A3P, are the most promising next-generation biomarker in testicular germ cell tumors. Preoperatively elevated in 80 to 90% of both seminoma and non-seminomatous germ cell tumor, with levels correlating with metastatic burden and with higher discriminatory accuracy than conventional markers in several studies. However, the European guidelines does not recommend microRNA testing in routine clinical practice. The key barriers remain being lab standardization is not established, the availability of the test is very limited, and prospective prognostic validation is lacking. Importantly, just like alpha-fetoprotein and beta-HCG, microRNA is not expressed in teratoma, which limits its use in non-seminomatous germ cell tumor monitoring. However, this is an active area to watch, but not yet something to act on in daily practice. Inguinal ochiectomy with division of the spermatic cord at the internal inguinal ring is the standard of care and comes with a strong recommendation from the European guidelines. The scrotal approach must be avoided because violating the scrotal skin disrupts inguinal lymph node drainage and introduces the risk of local recurrence in the lymphatic territory not covered by the standard retroperitoneal nodal surveillance. The spermatic cord is usually divided at the internal inguinal rings, specifically to allow accurate pathological T-staging and to minimize local tumor contamination. Two important additional points. First, markers must be measured before surgery. You cannot calculate half-life decay or define the 5 categories if you do not have a pre-op baseline. Second, there's one exception to the ochiectomy first rule. In a patient with life-threatening metastatic disease, such as massive lung metastasis or hemodynamic instability, the guidelines give a strong recommendation to commence systemic chemotherapy before ochiectomy. The cancer won't wait. Finally, testicular prosthesis should be offered to all ochiectomy patients at the time of surgery or subsequently, and this also comes with a strong recommendation. For pathological examination of the testes, the ochiectomy specimen must be handled according to the ISUP recommendations. The key elements of the pathology report are tumor size, the WHO 2022 histological subtype, percentage of each component in mixed germ cell tumor, as well as the presence or absence of lymphovascular invasion, retitestis invasion, both of which are both pagetoid and stromal, as well as hilar soft tissue invasion, tunica albuginea and vaginalis involvement, as well as spermatic cord involvement, surgical margins, and the germ cell neoplasia in situ in the background testis. Of these, lymphovascular invasion is the single most important prognostic feature for CS1 non-seminomatous germ cell tumor. Lymphovascular invasion positive patients have approximately a 50% relapse risk versus 15% in lymphovascular invasion negative patients. This directly drives adjuvant treatment decisions. We now move into staging. The 2026 European Guideline adopts the UICC TNM 9th edition from 2025. For the primary tumor, PTIS is germ cell neoplasia in situ. PT1 is tumor limited to the testes and epididymis with no lymphovascular invasion and no penetration of tunica vaginalis, though the tunica albuginea can be involved. The AGCC 8th edition further subdivides T1 seminoma into T1A for tumors 3 cm or less, T1B for those greater than 3 centimeters, but this subdivision is not present in the UICC 9th edition. Pathological stage T2 introduces lymphovascular invasion or invasion into the hilar soft tissue, epididymis or tunica vaginalis. Pathological stage T3 is spermatic cord invasion, and pathological stage T4 is scrotal invasion. These progressively worsen local staging and directly link to adjuvant risk stratification. The nodal categories follow anatomical size thresholds. N1 is a mass 2 cm or less, or multiple nodes, none of which exceed 2 cm. N2 extends to 5 cm or has more than 5 positive nodes, and N3 exceeds 5 cm. For distant metastasis, M1A is non-regional node or pulmonary disease, while M1B captures all other visceral, bony, or brain metastases. M1B disease carries a significantly worse prognosis. The S category for serum markers is a unique and mandatory component of testicular cancer staging, not seen in most other solid tumors, T&M stage systems. It is assessed using pre-chemotherapy values, measured on the same day as the first cycle. S0 is normal. S1 to S3 reflect escalating markers elevation of LDH, HCG, and alpha-fetoprotein, each having a defined threshold. This S category feeds directly into the stage groupings and determines whether a patient falls into stage 1, 1S, 2A, or higher. So next we'll talk about the stage groupings. Stage 1A is the ideal scenario. Pathological T1, no nodal involvement, no mets, and fully normal markers post-orchidectomy. These patients have excellent prognosis and are candidates for active surveillance. Stage 1S is clinically important and underappreciated. This is persistently elevated or rising markers after orchidectomy. In the absence of radiographically visible metastatic disease, it affects approximately 5% of non-seminal matrix germ cell tumor patients and indicates subclinical metastatic disease. Before assigning stage 1S, you must exclude a contralateral germ cell tumor as an alternative source of marker production. Stage 2 and 3 are defined by nodal and distant metastasis involvement respectively, with the S category further defining prognosis within each group. For clinical stage 1, risk stratification for seminal matrix germ cell tumor. 75 to 80% of seminoma patients present with clinical stage 1 disease, and the overall relapse rate on surveillance is approximately 15 to 17%. The vast majority are cured by orchidectomy alone. The European guidelines in 2026 has updated its position on clinical stage 1 seminoma risk stratification, reflecting two major new data series, tumor size and reticestis invasion, specifically both pagetoid and stromal components, and lymphovascular invasion have emerged as independent predictors of relapse in multi-institutional retrospective data. A Danish prospective series of 924 patients with central pathology review also identified elevated pre-op HCG and LDH as independent predictors. However, the European guidelines is explicit. The level of evidence for these risk factors remain low, and they should not be used to mandate adjuvant treatment. Surveillance is the preferred strategy for all clinical stage 1 seminoma patients, and risk stratification informs the discussion about surveillance intensity, not whether to give carboplatin. What about clinical stage 1 non-seminoma? For clinical stage 1 non-seminoma, the story is more straightforward. Lymphovascular invasion has long been the dominant risk factor, and approximately 50% relapse risk in lymphovascular positive versus 15 in LVI negative patients. Additional factors from the Danish series, such as tumor size, hilar soft tissue invasion, and embryonal carcinoma component, can further stratify risk with relapse probability ranging from under 5% to over 85%, depending on the combination of factors present. Stage 1S, which is rising or persistently elevated markers post-orchidectomy, affects about 5% of non-seminal germ cell tumor patients, and represents subclinical metastatic disease that requires active management. Next, let's talk about staging. Contrast-enhanced CT of the chest, abdomen, and pelvis is the cornerstone of staging imaging and earns a strong EAU recommendation for all confirmed testicular cancer patients. For the abdomen and pelvis, contrast-enhanced CT has a sensitivity of 67 and specificity of 95% for nodal metastasis. Sensitivity falls with smaller nodes, so knowledge of expected drainage patterns is essential. Para-aortic and inter-aortocaval nodes are the primary landing zone for right-sided tumors, while left-sided tumors drain to the para-aortic and left renal hilar nodes. Report all nodes in the 3 dimension. For the chest, contrast-enhanced CT has a sensitivity of essentially 100% and specificity of 93%. Even small, indeterminate pulmonary nodules under 1 cm are clinically relevant in the context of testicular cancer and should prompt careful documentation and serial follow-up. If a patient has a contraindication to iodinated contrast or is young and likely to require multiple follow-up scans, abdominal and pelvic MRI is an acceptable alternative with equivalent sensitivity for nodal staging. What about special imaging situations and PET-CTs? Brain and spinal MRI should be performed in 4 specific clinical situations. First, multiple pulmonary metastasis. Second, poor prognosis IgCCC risk groups, or HCG greater than 5,000 international unit per liter, or clinically neurological symptoms. MRI is the preferred modality. It is far more sensitive than contrast-enhanced CT for parenchymal brain lesions. Use contrast-enhanced CT brain only if MRI is contraindicated or unavailable. For FDG PET-CT, do not use it for initial staging. This is a strong recommendation in the 2026 European guidelines, and it is aligned with NCCN 2026. PET has limited diagnostic accuracy for staging before chemotherapy. It is not endorsed for this indication by either guideline. Similarly, bone scan has no role in the initial staging workup. The one nuanced area where EAU and NCCN differ slightly is for PET-CT for residual seminoma greater than 3 cm post-chemotherapy. The EAU recommends it in that context, while the NCCN includes it as a Category 2B option. But that is post-treatment management and not initial staging. What about post-orchidectomy tumor markers? Markers must be repeated following orchidectomy and interpreted in the context of their half-life. Alpha-fetal takes 5 to 7 days to halve, HCG takes 1 to 3 days, and failure to decline at the expected rate or any rise after orchidectomy indicates residual or metastatic disease. Critically, marker normalization after orchidectomy does not exclude metastatic disease. Micrometastasis can be present despite fully normalized markers. This is why staging imaging remains mandatory, regardless of post-operative marker status. Markers serve 4 sequential clinical roles: staging, IgCCCG risk classification at the time of metastatic disease, monitoring treatment response, as well as detecting relapse in follow-up. If the markers are persistently elevated or rising after orchidectomy, treat this as stage 1S until proven otherwise, and first exclude a contralateral tumor. The IgCCCG prognostic classification for metastatic germ cell tumor originally was published in 1997 and was revalidated on a contemporary cohort. It stratifies patients with metastatic germ cell tumors into good, intermediate, and poor prognosis group. For non-seminal germ cell tumor, good prognosis requires all of the following: a testicular or retroperitoneal primary, no non-pulmonary visceral mets, alpha-fetal under 1,000, HCG under 5,000, and LDH below 1.5 times the upper limit of normal. This will confer a 5-year progression-free survival of 90% with an overall survival of 96%. Intermediate non-seminomatous germ cell tumor has the same primary site and absence of visceral non-pulmonary mets, but with mid-range marker elevation, 5-year progression-free survival is 78%. Poor prognosis non-seminomatous germ cell tumor is triggered by any one of the following: mediastinal primary, non-pulmonary visceral metastasis, alpha fetal over 10,000, HCG over 50,000, or LDH more than 10 times the upper limit. 5-year progression-free survival is 54%, and this group receives intensified treatment. For seminoma, there is no poor prognosis group. Seminoma with non-pulmonary visceral mets is intermediate, and all other seminoma is good prognosis. 5-year overall survival in seminoma now reaches 95% in the good prognosis group. The updated IGCCCG revalidation confirmed that older age and lung mets are additional negative prognostic factors for progression-free survival. So how does the EAU and the NCCN 2026 guidelines differ? The two guidelines are largely aligned for the diagnostic workup. The main divergence are the TNM edition. EAU uses UICC 2025 9th edition. NCCN still references AJCC 8th, which subdivides T1 seminoma by 3 cm size. Brain imaging triggers. EAU explicitly specifies HCG greater than 5,000 as a threshold. NCCN is less explicit. For clinical stage 1 seminoma risk factors, EAU is more conservative, favoring surveillance over adjuvant treatment. NCCN uses the same risk factors to guide adjuvant radiotherapy or carboplatin options. And the EAU is more specific about contralateral biopsy risk thresholds. Both guidelines firmly agree: no PET-CT for staging, no bone scan for initial staging, bilateral ultrasound is mandatory, and markers before and after orchidectomy are mandatory. Contrast-enhanced CT of the chest, abdomen, and pelvis is also used for staging of all patients. This slide summarizes the integrated pathway. The sequence is straightforward. Clinical suspicion triggers bilateral scrotal ultrasound. Preoperative markers of alpha-fetoprotein, HCG, and LDH are drawn. The patient proceeds to inguinal orchidectomy. The specimen undergoes pathological examination with ISUP guided reporting. Post-operative markers are repeated per the half-life. Contrast-enhanced CT scan of the chest, abdomen, and pelvis is performed for all as a form of staging. A brain MRI is added for specific high-risk indications. And then we apply the UICC TNM staging, including S category and stage grouping from stage 0 to 3C. For stage 1, we re-stratify. For metastatic disease, we apply the IGCCCG classification. Here are the EAU 2026 strong recommendations for diagnosis and staging, summarized on a single slide. Note that all the strong, except the self-examination, which is graded weak due to the absence of high-level screening evidence. The rest, things like sperm banking, bilateral ultrasound, physical examination, markers pre- and post-orchidectomy, contrast-enhanced CT, brain MRI triggers, no PET-CTs, testicular prosthesis, contralateral biopsy is high in high-risk patients are all strong. This should be embedded in your clinical practice for every patient presenting with a suspected testicular germ cell tumor. Let me close with 7 take-home messages. 1. Any solid testicular mass is malignant until proven otherwise. Bilateral ultrasound is mandatory and immediate. Measure markers before and after orchidectomy and interpret the kinetics. A value without a half-life context is incomplete information. Contrast-enhanced CT of the chest, abdomen, and pelvis for all patients, and the brain MRI is only for specific high-risk triggers. No PET-CT, no bone scan for initial staging. Use the UICC TNM 9th edition, and remember the S category is a required component of staging. It's not optional. We apply the IGCCG classification at the time of metastatic disease. It determines treatment intensity. And for clinical stage 1 risk stratification, it informs surveillance intensity, not mandatory adjuvant treatment. The European guideline continues to favor active surveillance for the majority of stage 1 patients. Thank you for your attention.